All right, good morning, everyone. Happy Monday. I can't believe it's November, just sort of snuck up on us way too quickly for my liking. I hope everyone enjoyed a really nice weekend. I think it was the sort of, for Halloween, it was kind of the closest to what it felt like in the before times, as we refer to it. I'm really excited for this morning's session. And I'm really happy to be joined by Devon and Shaz, who will introduce themselves in a moment. This is really, like a coming out party, I would say, for this project. Many of you on the call would have been connected in some way to this project through our deliberative dialogues coming up almost a year ago now, and maybe even through some of the consultations that have taken place over the last year or so of this wonderful project, which we call TIP, the Trans Interweaving Project. So we'll rewind just quickly for folks who may be newer in their roles or less familiar with this project. Let's go back to 2019. The GMSH was working with a group of trans and non-binary folks to update Primed, which was and still is, a sexual health guide for queer, trans, and non-binary people. And it was through that project that the team recommended to the GMSH, really in the interest of wanting to continue to contribute to our work, continue to stay engaged. They brought forward recommendations about ways that the GMSH, if going down similar paths with resources, we could strengthen our efforts to better serve and integrate trans and non-binary people in our work. And I mean, I think it's fair to say that over the last, oh my gosh, several years now, while our sector has in some ways continued to be much more binary, the experiences of folks in the community is anything but. And there's been this real, shift and, fluidity that has emerged with respect to gender diversity and expression, which is a wonderful thing. And the GMSH, we wanted to know how we could be a part of that shift in a really meaningful way. And so we started this trans-led project to discover what the GMSH could be doing, which by extension, extended to our alliance members and then the sector more broadly, recognizing that we each have a role to play in serving trans and non-binary people in our work. And so we wanted to explore what we could do to improve our practice, what our role could be at the GMSH, understand the current state of engaging trans and non-binary folks in the GMSH and across the sector, and then to create recommendations. And so that's what brings us here today, is we have a lot of information to share. And our hope is that by the end of this session, that everyone on the call can connect with one or several of the recommendations that we're going to share. I'm just going to share my screen here. Bear with me. All right, so here we are, lessons from the Trans Interweaving Project. Start with a land acknowledgement. Participants in this project, including on the team, on the advisory, and folks who contributed, lived, worked, played on different territories across the province. And for the GMSH office here in Toronto, that's the traditional territories of the Mississaugas of the Credit First Nation, the Haudenosaunee, and the Huron-Wendat. I also just want to speak to the intentionality in this project with respect to Two-Spirit participation and engagement. Really at the heart of this work were decolonizing practices, right? So this included the Indigenous-led design of the methods to engage with Two-Spirit and Indigenous folks, respecting the oral methods and traditions of knowledge sharing in Indigenous communities, and working with knowledge keepers and elders. And I think, based on what we heard from participants, these approaches could certainly be leveraged across, a variety of initiatives. We want to turn it over to a poll to better understand who is currently joining us today. So Andrew, if you could pull up the first poll. So in what position are you joining us today? Please let us know. We'll just give everyone a few moments. All right, great. So we've got some executive directors and managers, alliance members, really wonderful, other frontline staff. All right, thanks. I mean, this is, the aim for this was really to have as many perspectives as we could in this space today. And each of the audiences that we described there also contributed to this project through key informant interviews, through our deliberative dialogues. And so we hope, that today's session offers learnings and a little something for each of you in the work that you do. Thanks. I'm going to turn things over to Devon MacFarlane, our project lead on the project.
Great. So what we're going to cover today is a fair bit about what does trans inclusion look like. We also will cover some of the strengths that the organizations think strengths we're hearing are already present in the sector for trans inclusion, as well as some of the barriers, and then we'll speak to recommendations about trans inclusion. But before we get into that, I want to talk for a moment about when we're talking about trans inclusion, who do we mean? Dane had at the beginning outlined that the sector has been aware of binary trans folks and that the breadth and diversity of trans communities is shifting. So in this project, what we wanted to do is we wanted to hear from trans, non-binary, and two-spirit people who describe themselves as being currently or formerly connected with gay men's communities and or sexual cultures. So not only trans men, but also trans women and non-binary people, whether assigned male at birth or assigned female at birth. So quite a diversity of trans people who describe themselves as being connected with gay men's communities and sexual cultures. If we can go forward a slide. So I want to start off by giving you a smidge of context to help you understand this project and its findings. So we've known for decades that trans, non-binary, and two-spirit people have been living with and have been affected by HIV and AIDS. And to save us a little bit of time, I'm going to be using trans as an umbrella term for trans, non-binary, and two-spirit as we go through the presentation. I may speak specifically to Indigenous folks and two-spirit where that fits, may speak specifically to non-binary people where that fits, but generally I'll be using trans as an umbrella term. So in Canada, as early as the 1990s, Vivian Namaste and others were calling on national and provincial funders, researchers, and agencies to respond to the enormous gaps in service faced by trans people in regards to HIV prevention, treatment, and care, including for trans women, trans men, and people who today we might call non-binary. And what goes on for trans people in relation to the HIV sector, what goes on around strengths and needs are deeply connected to how health and social services, how HIV sector organizations, and trans community support and advocacy work is organized. There's a lot of challenges to trying to fit trans, non-binary, and two-spirit people into binary gender systems. Where do we go? For instance, in the context of HIV supports and services, where would a trans woman go who's HIV positive and seroconverted while she was living as a gay man? What if she identifies as a lesbian now and is in a relationship with another trans woman? What if neither of them have had genital surgery? What if they both have? Does that make a difference? Where do they go for this kinds of supports that they need? What if anal sex is a regular part of what they do? Just for one example, there's lots of examples that we can talk about. How do we fit? Where can we go to get the supports that we might need? There's also massive gaps in epidemiological data. There's gaps in information. There's gaps around what's going on for trans people. There's also massive gaps in access to care that some of which is really important for you to understand when we talk about the indicators and recommendations later. For instance, around gaps in access to care, 45% of trans people compared to 4% of the general population described an unmet past year health need. That's pretty huge. And then trans people also may avoid care. There's a range of forms of structural discrimination that affect trans people across the social determinants of health. That's super visible in terms of the very high poverty rates that trans people experience. As 50% of trans people, according to the Transpulse survey, have incomes of under $30,000 a year. There's also high rates of violence, including sexualized violence. Part of what we know from one Ontario study that linked data from trans people who are accessing trans care clinics with clinical and administrative data is that HIV rates are 16 times higher for trans people than for the general population in Ontario. But we don't have a ton of HIV monitoring data available around trans folks yet through HIV system structures at this point in time. But what we do know is that there's also lower engagement in the care cascade. For instance, 8.3% of trans women have never accessed HIV care, compared to 2.6% of trans women. So not have trans people always been in existence, and been within the HIV, affected by HIV, but we've also been change agents. We stand up for ourselves, we stand up for each other, we make waves, and we contribute to change through, for instance, through this particular project. If you're wondering about the photo, this image is from the Compton's Cafeteria riots that happened in San Francisco in 1966, so 3 years before the Stonewall riots. And like the Stonewall riots, it was a response to constant police harassment of drag queens and trans people. So we've always been here, and we've always stood up for ourselves. Can we move forward a slide? So, as Dane mentioned, I was leading the Trans Interweaving Project. Other members of the project team were Rabi Ahmed, Yasmin Prasad, and Joël Xavier. Unfortunately, as they all have day jobs, we all have day jobs, they weren't able to join us today. But collectively, across the group of us, our experiences included racialization, immigration, living outside of Toronto, and both Francophone and Anglophone experiences. I was the only white Anglophone on the project team, and that was a pretty cool experience to have that breadth and depth of experience on the team. Collectively, we have probably now close to 60 years of involvement in trans communities and trans health across the four of us. Can we move on to the next slide? And Shaz, you're up for this one.
Yes. So the advisory committee, the TIP advisory committee, Trans Interweaving Project, was formed, and members of the team included Makiki, Anwar, Jerry, me, Stephanie, Tatiana, Victor, Elmer, and Yosh. It was groundbreaking for myself because I've, never been on an advisory that had, 2/3 trans and non-binary folks on it. And we were able to make decisions regarding, the project itself. So that was really great. We were committed to five principles, and they were to seek out perspectives from trans people, trans men, trans women, non-binary people, and two-spirit people who describe themselves as being currently or formerly connected to gay, bi, and queer men's communities or sexual cultures. An approach grounded in intersectionality, decolonization, liberation and empowerment, to apply the principles of nothing about us without us in concert with systems change principles, that perspectives in the system needs to be reflected throughout the project, to use a community-based approach with the goal of cultivating change through the process as well as the end products, and to use a strengths-based and appreciative approach to identify what is working and could be built upon. So these were the 5 principles that guided the TIP advisory. And I will turn it over to Devon.
Okay. Could you advance the slides, please, Dane? So building on what Shaz had been talking about in terms of what are the principles that we're engaged in, that shaped the methodology we used in this project. I'm just going to touch on the methodology because I suspect most of you are here because you want to learn about the indicators, want to learn about the recommendations. Oh, shoot, sorry, I have a light problem, apparently. Maybe that's a bit better. So what we did, because we were thinking about how are we going to make sure that we're hearing from the parts of trans communities who don't often get heard about, how are we going to make sure that the system, the perspectives of the system, the whole piece around nothing about us happens in the context of this project. So we organized a number of group conversations, some specifically with trans people, a few specifically with I'm realizing the group conversations that were with the GMSH staff and trans staff aren't on this list. That was a bit of a mistake. But we not only organized group conversations with members of trans communities, and we, as you can see, we had about 7 or 8 groups focusing on trans communities. We also organized 2 with GMSH linked staff and 1 for trans staff who are working in any role in any HIV sector organization. On top of that, we held 4 interviews with PAUSE trans folks and 4 interviews with HIV sector management. And 2 of those HIV sector leaders brought in a colleague, so we reached 8 people and 6 people in total. And then, as Dane mentioned at the beginning, we held a deliberative dialogue that was almost a year ago in order to take a look at the early findings and think about what could be done. How can we take action on this? What we're hearing as possible areas for action, possible areas for intervention. Across the entire project, over 110 people participated in at least one of the data gathering activities. We had 76 people in groups and interviews, and we invited them all to complete a survey so we could understand whether or not we're reaching the participants we hope to reach, and to be as transparent as possible about who we reached and who we didn't. 47 people completed the survey. That gave us about a 63% response rate, which is pretty decent. So in this slide and the following slides, in the next and the following slides, we'll be giving a smidgen of information specifically about the 32 trans and non-binary survey respondents. Can you move forward a slide, please? So as Dane mentioned, we've got a huge number of folks in trans communities who identify as non-binary. People, for instance, might look at me and assume that I'm a binary identified trans man. That's not language I use. I would describe myself as trans. Yes, I describe myself as connected with gay men's communities as well. Can we move forward? So this slide outlines sexual orientations amongst respondents to this survey. So more than 3/4 identified as queer, 40% identify as gay, so on and so forth. You can see that we had a range of identities, and people, of course, as you can tell from this, were invited to tick all that apply when it came to their sexual orientation. Can we move forward? Of our trans participants, 13% described themselves to us as being HIV positive, and 6% were negative and on PrEP, and the rest were HIV negative. Racialization. We had 54% of the participants who identified and are perceived as white. Another 18% who is more complicated, whether they see themselves as racialized, but they're not consistently treated that way, or they're seen as white, but their own history is a lot more complicated than that. And then 28% said that they're racialized. We also asked a lot of detail about, tell us about your ethnicity. Not getting into that level of detail in these slides just for time. Can move forward. A quarter of our participants weren't born in Canada, were newcomers. And 75% were born in Canada. Next slide, please. We had participants from across the province. So while half were from Toronto, we had 10 from the eastern part of Ontario. This is not the LINs, but how the health regions that they're now being considered in Ontario. So eastern is from Scarborough through to Ottawa and up to the edge of the northern part. We had 3 people from Central, so those are some of the cities just outside of Toronto, so Brampton, Mississauga. That we had 2 from the north and 1 from southwestern Ontario, and 1 who lives in Quebec and accesses support and services in Ontario. So we're next going to get into what inclusion looks like. This is some of the juicy part. So in our conversations, we asked and we heard what people wanted to see in terms of inclusion and integration in the HIV sector. I'm going to try and move in my laptop again so that hopefully you can see me and not be blinded by the light coming in through my window. So what we framed this in our thinking was around inclusion indicators. What would you see? What would we see when trans folks are thoroughly embedded in the HIV sector? Part of what we heard at times is that people being a little concerned that maybe in the HIV sector at times people may get a bit stopped by thinking about pronouns and access to washrooms is what inclusion entails. And yes, but that's part of what we heard is quite a basic element of it. So as we go through this section, I hope that you'll think about, in your context, what might be 1 or 2 inclusion indicators that you might want to take on? What resonates? What do you think you're doing well? What makes sense that you might want to consider for now or for the future? And you may want to think about, okay, if we start with these, and what might we take on in the future to build on that as you work to build trans inclusion and integration in your context over time. We will have the report available in the future, not too distant future, so that will also give you an opportunity to look at more depth around this, because in this presentation, we have to skim the surface. There was so much great stuff that we heard. Can move forward, please. So I'll start off by walking you through some of the specifics of what inclusion and integration looks like for specific parts of trans communities. And this will be giving you a flavor of that. So can we move forward? So around Indigenous communities, Two-Spirit folks, there were 10 indicators that came out of the data, out of what people shared with us. I'm going to be focusing in on 3 of them. Practicing solidarity, being accountable, and structuring sustainability. Solidarity and accountability were closely linked. Participants indicated that they would see solidarity being practiced across the organization, be happening across all programs and all staff. And by solidarity, what was meant was actions that follow an ethical commitment to address anti-Indigenous injustices beyond issuing an apology. And addressing anti-Indigenous attitudes and behaviors quickly and transparently was seen as an essential element of solidarity. We also heard that we'd see HIV sector staff and management making efforts in relation to both Indigenous and trans inclusion, knowing that can be risking mistakes, but being willing to risk making mistakes with the goal of doing better. Part of what would be seen with that is having concrete action plans with clear steps, timelines, and accountability measures. And related to accountability, a piece of that was also around ensuring that Indigenous-led work is sustainable and that it's supported with funding and capacity building work. Sustainability for Indigenous, Two-Spirit, and trans non-binary people who are employed in HIV and sexual health sectors included a recognition that agency unresponsiveness can lead to moral distress for staff. Participants mentioned how helpful it would be to have supportive structures in place, supportive structures that foster sustainability both for Indigenous staff and Indigenous-focused initiatives, structures such as advisory circles, as that way staff would have people to turn to outside of the organization as well, that can reduce the isolation, that can give them guidance, so that they'd have a breadth of experiences to draw from, not only their own lived experiences, but really it breaks a lot of the isolation that they can feel when a person is the only Indigenous or trans person on staff in an organization. Can you move forward? So this is a quote that we heard from one of our participants, that people doing this work need to be supported by a circle or a community council to help them in their development. They can't feel like they're the only Indigenous or trans person on staff. Otherwise, they'll be tokenized. Okay, so for Francophones, we had 7 inclusion indicators. The 3 that I'll speak to here are around linguistic accessibility, protecting confidentiality, and navigating service gaps. In serving trans Francophones, inclusion and integration looks like understanding how densely connected trans Francophone communities often are. And given this, taking extra steps to protect confidentiality of trans Francophones who are accessing or considering accessing HIV sector services. Participants recommended that agencies offer trans Francophones options for which staff to see, not just kind of automatically by default sending them to the trans Francophone, because these people may already know one another. This would help ensure that trans Francophones who are seeking services can actually make informed choices about who they want to share sensitive information with. One of our participants talked about working in the HIV sector and having to talk with somebody they already knew about this person's sex work experience, and that's not something that he should have known given his social connections. Another piece about helping it be easier for trans Francophone services people to access services is to clearly indicate the services that the languages that services are available in, and also indicating the linguistic capacities of staff. That could be through email signatures, for instance, but also it could be through organizations seeking funding to make materials or programs more available to Francophones. The navigating service gaps part of inclusion, it could be, there's some interesting ideas that came up that I thought could be really useful. What came up there was that when services aren't available in French, or a trans person isn't comfortable accessing the services from somebody who's in their social networks, trans Francophones would be supported to access services virtually outside of their region. For instance, a trans Francophone from Windsor could virtually visit an ASO in Sudbury or in Ottawa, where there'd be linguistic capacity. And this approach, we thought, could be beneficial for many other populations that face barriers to accessing services locally, and could benefit from virtual support provided by staff and other agencies. Let's move on. So we had 5 inclusion indicators that were specific to racialized communities, and I'll zoom in on 2. Part of what came up from racialized folks that didn't come up in other groups was the need to foster social connections, that inclusion looks like having some spaces be available specifically for racialized trans people. And there'd be multiple ways of engaging in these spaces. Part of what we heard too is that sometimes these spaces might not focus overtly on HIV or focus overtly on gender identity and transition, but it's more that opportunity to connect. Others we spoke with expressed the need for HIV positive racialized and or Indigenous people who are trans to connect with their peers. We also heard from participants that inclusion of trans people in the HIV sector must encompass inclusion of racialized trans folks. While representation in images and narratives in the HIV sector certainly came up, people spoke to the need to go far beyond representation into being engaged in consultation processes and in decision making. Several participants noted that having trans people of color on staff at ASOs can help build stronger relationships with the participants and foster a sense of connection and belonging. Can we move to the next? In particular, one person spoke to the importance of having people who look like us talk about the importance of getting tested and the importance of taking your medications. That peer voice, that peer language was seen as critical. Let's move on. I know this is a lot of information. We have a lot to cover. We're trying to do it in a way that that will resonate and will land and be manageable amounts. We did hold a group that was specifically for folks who'd come to Canada, whether as immigrants or as international students or as asylum seekers and refugees. We did hear common themes, common issues come up across a lot of the data when we went and analyzed it. In this one, what we heard specifically that I'll speak to is about information for trans migrants. Accessibility, we heard, requires critical information to be available in multiple languages to meet the needs of linguistic minorities, and information needs to be framed in ways that are culturally relevant and culturally competent. Information also needs to be accessible in venues where trans migrants might seek information. So not all trans migrants will have access to common information sources. They may not know about HIV sector organizations in Ontario. They may not have family doctors. One example of the need for this kind of information is in a focus group. One person who's a newcomer was asking, where could he get information about PrEP? What was it? How did it work? And he hadn't heard about it before, and it was something that was really relevant for his life. So that's something that, how do we get information to people where they already are, was seen as a critical consideration. Let's move on to the next one. So we heard 3 inclusion indicators that were specific to sex workers, and I'll speak to one. Supporting survival sex workers was coming up specifically around a lot of recognizing that a lot of survival sex workers are racialized trans newcomers. A possible approach that was identified by one participant was to engage suitably skilled volunteers. There may be some more thinking needed around that, is it a peer position, is it a paid piece, or is it truly volunteers? But to basically mobilize community knowledge sources to help trans newcomers learn about resources available to them, and help trans newcomers who are doing survival sex work get connected with the available supports and programming so people aren't so isolated and can get the support that they need. So we'll now move into the inclusion indicators that outlines the 4 themes that arose from the consultation, and then drilling down into indicators that are for each of these themes. And these indicators, at times they're looking at sort of across the HIV sector, and at times they're drilling down into organizational levels and the levels of individual interventions. But they're grounded in a set of principles. The intersectional approach, pretty obvious. Meaningful engagement and greater involvement. That's also the whole piece around nothing about us without us. It's pretty obvious. And what we'll do is I'll tease out a little bit more about a strengths-based approach. This was something that Shaz had pointed to at the beginning in one of the principles behind this project. We heard from both trans people and cis participants the need to take a strengths-based approach that really celebrates trans people, trans communities, trans bodies, including in the context of having sex. One trans person we spoke to noted that they didn't see resources that talk about, for instance, gender dysphoria in regards to having sex with other people, and basically how to make sex a positive and affirming experience for trans people. That strengths-based approach also came up from a cis gay man in a management role who spoke about the need for work that builds empowerment and self-esteem for trans people, which he saw as being really vital in the context of syndemics for trans people. Across the entire project, as the team, we reflect on how seldom conversations about strengths and resilience and positive experiences related to sex and sexuality had surfaced, which we noted was a really stark contrast to the norms in cis gay men's sexual health work. We did hear a few stories about trans women as role models, trans women of color, and trans sex workers holding deep expertise that was real strength and value. But we noted how seldom overall strengths are told that really affirm and value trans people and trans people's contributions, and in particular, value trans women who are disenfranchised in multiple fronts. Instead, the dominant stories that we hear, not only in this project, but in our communities more broadly, are the stories around vulnerability that trans people can experience, trans women in particular. These stories really focus on that vulnerability and pretty much to the exclusion of any other kind of stories. And that can be damaging, which really brought us a lot of concern, which is why I'm emphasizing the strengths-based approach here. As a strengths-based approach to trans inclusion and integration would look at focusing on the skills, knowledge, resourcefulness, and resiliency that trans women have and other trans people have in navigating a society that's just full of systemic barriers for us. So I'm going to touch on a few of these inclusion indicators. A fundamental element of trans inclusion in the HIV sector involves setting and upholding a sector-wide intention of welcoming trans, non-binary, and two-spirit people in gendered interventions that we see as being relevant to us. We heard that inclusion of trans men who are gay, bi, or queer would very obviously fit in gay men's sexual health work. Given how many trans people identify as queer, there may be a piece around that about how to make sure that it's broadly relevant, not just around trans men having sex with other men, whether they're cis or trans. We also heard about inclusion entails ensuring that volunteers, staff, management, and boards all have the knowledge and skills that are necessary for their roles, whether that's in relation to trans people, trans experiences, and transsexual health. We heard from quite a number of people about the need for trans people to be able to wield influence at every level of the organization. Supportive organizational systems include pieces like hiring practices such as job postings, payment or compensation processes working for trans people who haven't legally changed their name yet, means to address behaviors, attitudes, and approaches that aren't conducive to trans inclusion and integration, and more. We also heard that foundational and elements of inclusive and supporting and welcoming environments entail being called by the right name and pronouns is kind of basic, but also knowing that mistakes happen. And so for people to have an open and non-defensive response, cis people are making these mistakes usually when these mistakes happen. For trans people to see themselves reflected amongst staff and volunteers when they're coming into youth services and working environments that are really supportive of trans staff. and creating means for trans people across the HIV sector to connect and to reduce isolation. Let's move forward. So part of this is about creating healthy work environments so that trans folks on staff can produce better work. Let's move forward to inclusion indicators in interventions. Part of this is around inclusive language and approaches and how that gets used in day-to-day programs and services, whether that's in online outreach, community outreach, and harm reduction. Part of it too is about sexual health interventions that are relevant for trans people and reflect our needs. And reflect that based on whether we're new in our transition and now we're at self-exploration journey, or whether we transitioned 15 or 20 years ago. But also part of that's about getting the concrete knowledge that people need, like how does PrEP absorption work for trans people who are having receptive genital sex, depending on what tissues they have, depending on whether these tissues have been modified through hormones and or surgeries. Let's move on to inclusion in healthcare. So the one inclusion I'll focus on here, recognizing that some of you may have health services connected with your organization, but others might not, is the desire for health systems and health organizations overall also to take an intentional approach to trans inclusion and integration. So this involves taking responsibility for ensuring that trans people are actually receiving patient-centered care that meets their needs, and that the need to normalize trans healthcare and medical systems. And part of that includes making sure that healthcare providers have the knowledge and skills, and that making sure that there are clear complaints processes that build trans people's confidence that they won't run into further transphobia and or racism when they're bringing forward a complaint. So that's a super high level look at some of the inclusion indicators, and I'll hand this over to Dane now.
Sure, thanks, Devon. And so we have a second poll based on what you have heard from Devon. I mean, we want to get a sense of, for your organization or your programming, based on what you've heard, kind of on a scale of 1 to 5, 1 being you're just starting to consider work in areas that have been outlined, or 5 being like you're really active, yes, you're feeling this, you're in it. Please give us a little sense of where you and your organizations are at in some of these areas. Thanks. All right, wonderful. So some folks really actively engaged, others, I would say, kind of middle ground, which is excellent. I mean, that shows that there's opportunities as well. It's really wonderful. So in the interest of time, I'm going to share, I get the fun part. I get to talk about all of the good things that are happening within the sector and across programs and services. This is really important. I mean, we heard from Devon, you know, you were describing that strengths-based approach, which is critical. We wanted to elicit hope in this project and motivation. You know, so often we really focus on the challenges, and we think there are actually, you know, really wonderful things happening within this sector that can grow and be expanded on and can inform our work at the GMSH and in the Alliance. And so I'll speak to a few of these. These are just high level what they were. It was employee and management experience, actions that leaders are taking, strengths for folks in accessing care, programs and services, and structural strengths. I really like this quote. Some of my best experiences were volunteering with ASOs. They were the first places that I saw trans people being centered, if not by the agency, but by the people, and that creates a lot of safety. The first trans people I met were working in ASOs, important and revolutionary for trans and non-binary people because there's no space for our community. And so we know the sector has been working to advance inclusion for a range of populations for some time and throughout our history. And there's no doubt that we are a sector full of big-hearted, wonderful people who care very deeply about the communities that we serve. And that this really stems from values on which the HIV movement was built. And so because of all this, we think the sector is ready. And for those folks who maybe just rated themselves previously as a 1 or 2 or a 3, certainly ready to push forward to a 4 or a 5. And so I'll speak first to employee and management experience, just really briefly on HR related topics. So we've heard from leaders in the sector through our one-on-one consultations, kind of work that's happening formally and informally to advance inclusion. And different organizations reported offering different development practices, right? So one leader spoke to specific hiring practices within their organization, which included clear language on job postings, encouraging folks from the trans community to apply and to seek out opportunities at the organization, ensuring that equity factors and lived experience is part of the hiring process, and having folks from the community on hiring panels when hiring folks from the community. I'd say at the GMSH, like many, programs and organizations, we're limited, there are limitations, right, on the number of staff that we have that are part of our budget and our agreement with the ministry. But that doesn't mean that we haven't been able to create space for trans and non-binary folks to participate in our work. And so that's happening through particular project roles, right, contract opportunities, paid opportunities where trans people get to contribute to our work, develop some of their skills, and learn and grow. And that will create future opportunities for their engagement in the sector, maybe within some of your organizations, but also communities are close and many are tight-knit. And we want to be a space in which trans and non-binary people hear about the GMSH, hear that we're a place that aligns with a particular set of values, and to contribute to our work and work with us. On the partnerships and collaborations, this is critical, and it came up especially in smaller rural and suburban communities, where organizations, for example, one of the examples listed was regional multi-agency tables, right? So being part of local coalitions to improve care, to improve coordination of services, and to collaborate was really important. We heard from one of our alliance members, work with their local public health unit on HIV and STI testing and the work that they were doing to prepare staff at the health unit, right, to ask better questions, to be more inclusive for trans and non-binary people. And we see this across other PPN work. So Y, for example, and their work to train folks in the violence against women sector to welcome and care for trans women. On the programs and services side, a lot of strengths here in resource developments, in campaigns. We heard that increasingly programs are becoming more inclusive, and in some areas were perhaps less developed. And the importance of having trans staff lead initiatives for trans and non-binary people. I'll just touch briefly on relevant resources. One that came up a lot was Primed, which was commissioned by the GMSH, developed by a group of queer, trans, and non-binary folks, and the other being Brazen, which is a sexual health guide for trans women. Outside of those two resources, there weren't a lot of other resources that were identified, but I do want to, give acknowledgement where it's due. I know, for example, different communities, I know the ACT, AIDS Community of Toronto, has developed some recent sort of localized campaigns related to empowerment of trans and non-binary people in sexual health care. And so certainly there are other resources that we should all be aware of and can probably utilize in our work. On the care cascade, comes up so much in our work. We heard of strengths in accessing trans primary care, as well as testing and treatment. Some of these included really overtly trans-inclusive testing initiatives, right? Or special clinics and testing nights for trans people. Arch in Guelph, for example, has a well-established program where folks have access to testing and counseling and specialist care. ACT for years now has, I know, undertaken activities to make its HIV point of care testing more appealing to and affirming of trans people. And where organizations maybe aren't offering those services directly, we heard a lot about networks of providers that were working together and the importance of organizations making warm referrals. Trans people continue to tell our sector what to do, and that's what gives me hope, was a message from one of our participants. On the structural side, I'll touch on syndemics and leverage for the GMSH. So two HIV sector leaders spoke to syndemics, which is evidence that for years has informed gay men's HIV-related work, right? That there are certain psychosocial challenges experienced in our communities and that they co-occur together. And that this framework and understanding could be helpful if it was extended to trans people and to identify interventions that address some of the root causes for HIV vulnerability and challenges experienced in the community. And then finally, we heard that there was a lot of leverage for the GMSH in this work, and sort of a call to action for us to take up a bit more space, to be a bit more vocal, and to assert a greater sense of influence in these areas. So I'll just wrap by saying, these strengths provide a solid foundation for this work moving forward and for cross-sectoral initiatives and collaborations to advance trans inclusion. So, we heard from Devon what trans inclusion and integration could look like. And I've showed a little bit of some of the strengths that we heard and approaches that can help move us all forward on this path. But we need to also touch on barriers. And so when you see the report, you'll see that it's a bit binary in a way, in that we have strengths and then we have barriers and obstacles and challenges to inclusion. They covered 4 broad themes that came up across all of this work, including structural challenges, mindset and beliefs, and challenges for people who might consider accessing ASOs and HIV-related services. So we'll kick things off by looking at lack of knowledge, which I'll just, really quickly just say, there was participants identified a broad lack of knowledge about trans health, trans sex, different HIV-related tools, for example, like PrEP and PEP, and really the need to scale up knowledge within the sector on trans care in regards to HIV and sexual health. Some of the workforce challenges will come as definitely no surprise to EDs on this call, but it related to turnover in both staff and in volunteers. And, you know, just I'll share a quote here that really speaks to sort of the costs of this turnover, which is that there isn't a lot of institutional knowledge that often gets left behind. And unless there's like transition plans for staff, they leave with so much information, and then we hire someone new, and we onboard them, and some of that historic knowledge is lost, and those relationships, which we know is a real challenge. And then finally, something that was particularly relevant for me at different stages throughout this project, and I hope other folks can perhaps relate with this, is that fear of making mistakes. And so frontline staff and management really spoke to this in relation to serving trans people. One HIV sector leader noted, so many people are frozen stiff by insecurity and by fear of doing and saying the wrong thing. And what we heard from participants from the community was, in a way, kind of move beyond that. Don't be so frozen. Take a risk, take a chance, actively engage, but you need to try. Barriers in the sector. Rural communities noted experiences of fewer supports, staff isolation, and then folks traveling significant distances to access appropriate care. Often, you know, we know too that ASOs, especially in rural communities or suburban regions, are often seen as the only place for LGBTQ related anything. And that comes with a significant amount of pressure and challenges, especially if your organization isn't resourced in a way to be that center for all things queer healthcare. In terms of access to services, one example was testing, where oftentimes assumptions are made about people accessing testing, about their sexual interests and behaviors, assessments related to HIV risk, and you know, the impact that that has on folks wanting to access care. Right? For example, if you're a trans man and you're continuously read as being a lesbian within clinical care settings, right? Would you really want to go back and engage with that space? In terms of some of the barriers in programming and service delivery, this one was interesting. A lot of our Alliance members, many of them, the vast majority, are providing sexual health promotion information and service online. And in some of our focus groups, we heard that there are often expressions of transphobia commonly found on social media and even on posts by HIV sector organizations, and that these organizations don't always remove these comments or address them, which conveys a message that these are endorsed by the organization or that they're okay, and that impacts reputation of organizations and programs. So we've covered a lot of ground, broadly looked at what the inclusion indicators are, both for different communities of trans and non-binary people. We have explored some of the strengths and opportunities in the sector, talked a little bit about obstacles, and now it's time for a break before we look at the recommendations and really, you know, how we intend to move forward. And so we hope that you will stick around for that and enjoy this next 10 minutes. So now for the juicy part. We've heard about the strengths, opportunities, challenges, and now we can look at what we want to do next to continue to move this work forward. And so I'm going to cover high level a few of the recommendations, and there are several. that have implications for the GMSH provincial office, for our alliance members, HIV sector organizations as well. So these build on suggestions that we heard from participants in groups and interviews, as well as in the deliberative dialogue. So we can see them here in the report. They'll be divided into 3 different areas: near future, medium term, and long term. Recognizing that this is not work that will happen overnight. It's actually setting us on a path for several years of work within the GMSH. So I just want to touch on a few things that will happen in the near future. And this is related to structuring in trans inclusion. And so I'll just give one example here. There are a number of steps right now for the greater, more meaningful involvement of people living with HIV in our work. As many of us know, the Ontario AIDS Network has recently kicked off consultations to renew the Ontario Accord and our sector's commitments to the Accord. And so for the GMSH, we'll be supporting these efforts by leading outreach to trans and non-binary people in that process to ensure that trans people are named in this next iteration of the Accord. Additionally, one of the sort of accountability mechanisms in the sector is the reference guide, which comes from the Ministry of Health to all funded programs. And the GMSH is going to continue to include activities related to the TIP project and recommendations in each of the forthcoming reference guides. Right, we hear the challenges of funding silos and a lack of guidance around how binary gender trans people can be served, and that this ranges oftentimes agency by agency. And so we're looking at our scope for trans inclusion. This will include making this a priority in our yearly planning, both internally and with our alliance members, engaging with the other PPNs, with our friends at ACTSHO and Y, to set clear understandings of how trans people are served across strategies, and including this work in our updated MOUs with alliance member organizations. On resources, looking at trans-focused content, resources, campaigns. I had mentioned this project stemmed from work that happened to redevelop the Prime Guide, which you can find at getprimed.ca. But that's not where this work will end. And we see the need for continued scale up of health promotion messages tailored by and for trans people in our work. We also, want to see much more rich content and different types of multimedia across our work as well. Participants, noted that there were some particular areas to address with alliance members to effectively reach and engage trans people. And so we're looking at establishing more clear and consistent guidance on how to do that work and to disseminate resources as well. In the medium term, looking at community knowledge mobilization, right? The importance of building capacity in trans communities in our sector, preparing them for leadership in the sector, and to harness all of the knowledge across communities. And so we've started exploring what this would look like. We know we have, for example, Totally Outright, which was designed and developed for young gay bisexual men. What would a Totally Outright look like for trans and non-binary people? These are some of the questions that come up in relation to this particular recommendation. And in the long term, This, really focuses on capacity at board management and frontline levels, looking at the development of more learning initiatives, working with our partners at HIV Resources Ontario to ensure that that consistent push of knowledge and to inform practice around trans and non-binary people. There were particular recommendations for HIV sector organizations to consider, one being related to transparency. So organizations, making their commitment to serving trans people visible within their organizations. One thing that we didn't touch on today, but that's included in the report, was the results of a sector-wide look at strategic plans, organizational and program websites, which did show some fairly consistent gaps in relation to trans people being named in those strategies, or as a community in which the organization serves. And we mentioned this as one of the strengths, but also furthering strategic partnerships, recognizing that no single organization will be able to meet the needs of all trans people, and that partnership and collaboration will be critical. There were recommendations that came up in our Two-Spirit group for Two-Spirit and Indigenous serving organizations, and these were related to just the need for holistic engagement across services, right? Things like access to traditional medicines, cultural programming, ceremony, as being really critical for Indigenous and Two-Spirit to reclaim what colonization has taken from them. So I'm going to pause there because we have shared a lot of great information, and we want to get a sense of how it's resonating, right, with regards to the indicators, particular recommendations, and so I want to open it up to folks on this call today to share reactions. And you can either feel free to unmute yourself and share, or share in the chat, however folks feel comfortable.
I wonder if we could see the recommendations all on the screen again.
Sure.
Thanks.
And I'm seeing that Adrian's hand is up.
Sure. While I pull this up, Adrian, please go ahead.
Just thinking throughout the presentation that it seemed like a million years ago that I was chatting with the project team about ACDR and the work we do with trans people and trans inclusion and hiring trans people. And it's just really cool to have that, to see the outcome of those conversations and to see how much work has been done, how much thoughtful work has been done. It's so easy to slap a band-aid on it and just sort of move high speed, but this is really obviously well thought out, and I just want to congratulate everybody because it's really great work.
Thanks for that, Adrian.
Thank you. And thanks for your contributions.
Mm-hmm.
Brian here from RHAC.
Brian, please go ahead.
Absolutely. One of the, I appreciate the work as well, and getting some real concrete information and some recommendations about how to move forward. The one thing that does strike me is that comment about paralysis that's created based on fear and that inability for people to move things forward. And I'm just wondering about how to actually tackle that with organizations, and what are the core areas of fear? Was that identified in this exploration? And just wanting a bit more information about fear, because I certainly have people do get nervous about, saying the wrong thing or introducing a program that doesn't have quite the right elements, isn't as competent as it should be. So I'm just looking for more, were there themes related to that fear that were shared?
That is an excellent question. I wonder, Devon, if you can speak to something.
Yeah, I can speak to that a bit. I don't have that part of the report open in front of me right now. What I'm recalling is, as you're saying, it's the fear of making mistakes. It's the fear of hurting somebody, of alienating somebody, but that sometimes can result in paralysis that has the same impact. One organization, one person that we spoke to in one of the focus groups talked about in their organization how they were practicing pronouns, using they pronouns, like with a stuffed animal in the office. So to try to get the pronouns just to have things come off people's tongue in an easier way that was a low stakes, no stakes thing. So I think some creative solutions around how to practice, do role play, do whatever that can help do that, but also help build people's confidence in their ability to repair. So it's like that oops, ouch, move on. Like, you make a mistake. We all make mistakes. It's normal. Trans people know that mistakes happen. And it's just, okay, thanks. Got it. You've apologized. Well, let's not talk about it for the next 10 minutes. I don't want to see you cringing in front of me. I just want to get my needs met. So that's part of it, about how to normalize that, yeah, mistakes happen. I think part of the piece around getting the programming right, some of the fear around mistakes may lead to less engagement in developing or considering the program that then is less likely to resonate. So I think some of that piece around how do we just chat with trans folks? How do you get, now that this resource is getting ready to be released, there'll be a lot more information available that will help people know how to nuance the questions they might have. Or things to think about that they may not have thought about already that I think will be helpful. Does that help address your question? I'm sure there's more, but that's a few starting points.
Yes, I appreciate that, Devon. Yeah, thanks very much.
If I may jump in a little bit, and I'm not sure, like this might not be in the report, but I wanted to stress the importance of education. And education can come in many ways, like the staff could, individually look for information, or you could have workshops, centered around like trans inclusion. And I know that there is an organization by and for trans folks and non-binary folks, and they do like educational workshops around, like, is your organization, ready? Is your organization, halfway there, whatever. So it'd be a good contact, and just like, again, like education through other workshops, through other resources, through research, and
Yeah, thank you.
This is a really great question. Actually, came through on the chat, which I think speaks to kind of the vision. I think moving forward for this project is, what do we think would change in terms of trans folks' experiences if everything we've discussed today were implemented?
That is a question that gives me so much joy. When I think about just imagining what might happen, what it might be like for trans folks to be able to get the supports and services that they need, be able to talk about sex and sex with our bodies, however they are, in a really normalized, celebrating, empowering way, in a way that people have that sense of, yeah, I'm enough, I'm cool, I'm hot. That people have access to role models. Man, the access to role models from staff working in the sector, from connecting with peers in a different way, that would be so powerful. I think HIV sector work doing that, if it were to happen, if everything were fully embedded, I think that would be in Ontario, I'm thinking like that would be a big contribution to improving trans people's health and well-being. It's not the entire thing, because there's so much more that's needed in society. I'm not expecting the HIV sector to do everything, but that piece around reduction in HIV-related risk, the increase in sexual self-esteem, sexual self-efficacy, all the pieces that can come along with that, the engagement in the care cascade, I think would be incredibly powerful. And I think part of what would happen is when you open up the doors, to serve a very marginalized part of the population, recognizing there's all these marginalizations that a lot of trans people face, given intersectionality, given racism, so on. When you do a good job about that, it opens up the doors for a lot of people. So I think that the potential benefits for cis folks who access HIV sector organizations is also could be significant.
Yeah, no, absolutely. I've heard, work, for example, to produce campaigns and resources and to have trans people really visible in materials. And like you say, positioned as being, hot and lovable and fuckable, like that work being really life affirming, especially for young trans people.
Yeah.
And so, for myself, I feel like it kind of gets at the heart of what we're trying to do.
Well, something that really the piece around it gives people, I think if this were done well, it would give trans people more of a sense of having a future, something that we heard in the consultations a couple of times that's a myth, and I've heard it so many other times, and each time I hear it, it breaks my heart. That sense that trans women, especially racialized trans women, this is a myth, that have a life expectancy, depending on who's saying this, maybe 26, maybe 36, maybe 28, whatever, it's a myth. It's an inaccurate information that's taken on a life of its own. But when people hear that, when they don't have that sense of having a future, of being powerful, like what happens in their psyches? What risks are they going to take? What sense do they feel like that they're going to have a life? So that's when I was talking about the strengths. We need to take a strengths-based affirming approach. That is critical.
Absolutely. And I think this can be summed up beautifully with this quote here, that trans inclusion and integration. It'll be necessary for us to address some of those unique elements that we heard from Devon for different populations of trans people, those who face compounding barriers to our sector and to HIV and sexual health related care, right? To leverage and grow our strengths and to address barriers and obstacles that stand in our way, right? Building on our history to serve folks who are disenfranchised in our communities.
Yeah. Can I also, I spoke to my sense of what might happen. If Shaz, I'm wondering if you'd like to share a little bit about your sense of what might happen as we think about if this report were fully brought to life. So I think hearing from you as somebody on the advisory committee, as somebody who works in the sector, I'd love to hear that.
If this were brought to life, I think among the smaller ASOs, I'm thinking of the smaller ASOs that serve racialized populations. I think, we are already, acting on that, on the recommendations. But you know, need to, I think we need to create a bigger sort of partnership with, you know, like the smaller agencies as well as the larger ones. And, you know, that in turn might or will lead to, you know, trans inclusion and integration. You know, integration is it's another step up from inclusion, because inclusion means that, hey, you're in our space, you know, and we have these things, you know, ready to welcome you. But, you know, we want integration, right? And that is like the ideal, because integration means that I'm already in the space and I get to make decisions and choices, you know, based on, you know, my role, my position, and, you know, that, you know, like, I think take an advisory, for example, an advisory committee, right? If we, like, if the organizations, you know, created an advisory committee of trans, non-binary, two-spirit people, then, you know, that would be one way that, you know, we could get integration instead of inclusion. Yeah, so I think, you know, that's what it would look like for me.
Thanks so much, Shaz. So before we wrap, also we invite folks to join us in the networking room to continue to connect on this and anything else that's coming up at the conference. But I just want to acknowledge several people. First, Devon as the project lead. I mean, just exceptional. I've like had like just being able to work with you, your attention to not only just the details of this work, but also not holding back what was possible through the project, and your openness and collaboration has been a real gift, I think, to me personally, but also to the GMSH. The project team, so Yasmin, Robbie, and Joelle, who couldn't join us today, but who have supported our work for years now at the GMSH. Members of our advisory team, including Shaz, thanks for being here and for all of your work to guide this project. And finally, to, you know, all of the trans and non-binary people who have always been here, who have passed, who are still here and doing the work both here in Ontario and really around the world to move the dial on inclusion and on justice for trans people in the HIV movement. Thank you. This is not the last you've heard of the TIP project. The report is currently going through a bit of a copy edit. It's going through some beautiful layout and design, and we hope to have it available to the sector very soon. I think it's a real gift to the GMSH and to the organizations that we work with. And we will continue to implement and move forward on these recommendations, some of them in this fiscal and others in years to come. And so you'll be hearing more about this project in various spaces over the coming weeks and months. And so thank you, everybody.